Good evening and a warm welcome to you all. I'm Alison Button-Sloan, the Advocacy and Community Engagement Coordinator with Melanoma Patients Australia. First, I would like to acknowledge the traditional owners upon the land we meet today, the elders past and present and those emerging. It's wonderful to be here tonight and to be holding the second webinar of our Melanoma Symposium series. We have over 180 people attending from across Australia, which is just amazing. And I thank you all for coming along. First up tonight, we'll hear from MPA's CEO and then on to our 4 expert guest speakers. So first is some housekeeping. We will be recording this webinar, which we will publish on our website in a couple of weeks. Now, down the bottom of your screens, you'll find the Q&A function. Now, this will give you the opportunity to ask questions anonymously, and we'll do our best to answer as many of those that we can. We will be holding 2 Q&A sessions. So, as you know, we're having 4 speakers. So after the first 2 speakers, we'll hold a session, and then with the last 2 speakers, we'll have a session then. So that will enable, I hope, for all the relevant questions to be asked at the relevant time. So now I'd like to introduce Victoria Beadle, Melanoma Patients Australia's CEO, who will give you an overview of our services. Thank you, Victoria.
Thanks, Alison. It's really wonderful to be here with you all tonight on this very special webinar on the topic of psychological health and wellbeing. On behalf of Melanoma Patients Australia, I extend a very warm welcome. This topic is an incredibly important one, and it sits at the very heart of the work that we do here at Melanoma Patients Australia. When our co-founders, Daniel Belcher and Brent Grace, met in a hospital bed in Brisbane over 15 years ago, they were both young men in their 20s recovering from surgery for life-threatening melanoma. They were shocked upon their discharge from hospital to receive a pack of information about breast cancer. They were young men in their prime receiving incorrect information. They set about ensuring that no one affected by melanoma would have to go through that, believing that all people diagnosed with melanoma had the right to receive the very best information and support. And following that, Melanoma Patients Australia was born to fill that gap. This story is why evenings like tonight are so important. We know that times are tough for so many of you at present, and the double task of dealing with melanoma during the COVID-19 pandemic is not an easy one. Looking after our mental health, finding ways to stay well amidst a global pandemic and a melanoma diagnosis are tough. I'm thankful that so many of you are joining us this evening to learn from our wonderful team of experts who will explore some of the most important topics that melanoma patients and their families want to hear about, including fear of recurrence, survivorship, diet, and exercise. I'd really like to thank our speakers for this evening. They're giving their time and expertise to us. And of course, our sponsors, BMS and Melanoma Institute Australia, who have made tonight possible. I'd like to remind everyone here tonight that you do not need to face a diagnosis of melanoma alone, and that there is help and support here at hand through the Melanoma Patients Australia supports. We offer a range of supports, including the National Melanoma Support Line, a range of support groups in varying formats across Australia. Currently, all of our face-to-face support groups have moved to a virtual format to make sure they're safe and accessible for many patients and carers wherever you are in Australia. Our closed Facebook support group currently has over 1,800 active and engaged participants working together to provide each other with peer-to-peer support in a very unique environment. We continue to deliver our national telephone support group in partnership with the Cancer Council in New South Wales for people with metastatic melanoma. And we now have a new telehealth melanoma nurse service generously funded by the Melanoma Institute Australia. and we're supporting patients in navigating the health system, accessing available services, and making key decisions regarding their health. Please reach out to us and find out more to be connected in to the MPA support network. Thank you, and I really hope you enjoy this evening and the presentations from our wonderful healthcare professionals.
Thank you, Victoria. So I would like to introduce our very first guest speaker, Professor Michael Jefford. I'll just give you a little background about Michael. Professor Jefford is a consultant medical oncologist and director of the Australian Cancer Survivorship Centre at Peter Mac, and is a professorial fellow with the University of Melbourne. Most of his research has a cancer survivorship focus, aiming to better understand issues affecting survivors, to develop and implement strategies to minimise post-treatment consequences, to develop improved models of care, and to better understand and minimise disparities in cancer survivorship outcomes. In addition, he is co-investigator on several cancer therapeutic and psychosocial studies. Prof. Jefford is widely published and has presented work at numerous international meetings covering clinical oncology, survivorship, psycho-oncology, and cancer control broadly. It's great to have you here tonight, Michael. Over to you. Thank you.
Thank you very much. I'm just going to try and share my screen. Thank you. So thank you very much for the welcome, and I'm going to talk a little bit about survivorship and also particularly issues experienced by survivors of melanoma, sharing some data that describes the experience for Australians with melanoma. So it is very close to home and relevant and pertinent to people in Australia. So I'm just going to get rid of part of my screen. Okay. So I'll focus a little bit on some definitions and some numbers, talk about some issues commonly experienced by cancer survivors in general, not just people affected by melanoma. And then we'll look at some of the experiences for people with melanoma in a couple of different settings, talk briefly about some of the issues that we have with current care and of Australian survivors, and some of the efforts to try and improve outcomes for survivors, and focus a bit on the Australian Cancer Survivorship Centre, which is based at Peter Mac. So who is a cancer survivor? I guess that this is, the term is used to define different populations, but we think of survivors from the time of diagnosis on for the remainder of their life. A little confusingly, perhaps, we use the term the survivorship phase as that period after initial treatment for cancer. And we know that it's a phase that's deserving of much more focus and attention. And I'll explain why, but we know that people have a broad range of unmet needs and persistent symptoms that perhaps we're not doing as good a job as we could at identifying and addressing. We know that the term survivor isn't for everybody, and some people like it and some people don't. It's a term that doesn't translate well to other languages as well. And so we'll often talk about life after cancer, or that phase after initial treatment for cancer, or living with and beyond cancer. So in Australia, there are a large number of people who have a personal history of cancer, and by 2014, there were over 1 million people in Australia with a personal history of cancer. That's 1 in 22 Australians, and we know that cancer generally is more common as we get older. So although it's 1 in 22 of all of Australians, it's a much greater proportion of people over the age of 60 or 70. Of course, survival rates are improving. Currently, about 68% of people are expected to survive beyond 5 years, and that number is increasing. We know that by 2040, then the number of people who are survivors is estimated to be about 1.9 million Australians. And this is true of countries around the world, that the number of survivors is increasing. The majority of people will be long-term survivors, so their diagnosis might have been 5 or 10 or more years ago. And also the majority of people will be over the age of 70. And that's important when we think about survivorship care, because many people are living with other illnesses too. Toward the bottom of the screen, I'm not sure whether you can see it, but the biggest group of survivors are people with a personal history of prostate or breast cancer, but there are over 250,000 people in Australia with a personal history of melanoma. The fourth largest group are people with a personal history of bowel cancer. So when we think about the issues that people experience, then I guess it's important to highlight initially, first up, that most people adjust well to life after cancer. And for many people, they have normal, enriching, full lives. But we do know that across different cancer types, that there are quite commonly people report varied reactions to finishing treatment. And so some people are, elated and full of joy to be finishing treatment, but many people describe feeling a bit, not like that they feel a little lost and abandoned at the end of treatment. And particularly people who have had quite intense engagement with the cancer team, perhaps they've been having a lot of serial, chemotherapy or immunotherapy, or been having quite a bit of radiation, then all of a sudden they don't have the support from the hospital team and can feel quite lost. We know too that there are persisting side effects after treatment and issues with fatigue, pain, concerns about sleep and cognition, and I'll show some specific information for melanoma survivors on this in a moment. We know too that emotional and psychological issues are very common, particularly the worry about cancer coming back. There are also side effects that can develop later that we call late effects, such as the concern about infertility, the possibility of damage to organs, or even the risk of developing another cancer because of previous cancer treatments. There are, of course, impact on family and relationships, and practical issues such as difficulty with work and study and impact on finance. Having said all of that, then we do know that some people report benefits and growth through the cancer experience. And for many people, it's a time of reflection and thinking about what's important. And people do commonly report personal and psychological growth through the cancer time and through survivorship. So I'm just now going to look at specific data about melanoma survivors. And this is work that was done in Victoria. So people were approached through the Victorian Cancer Registry. So it was designed to be representative of people, not just from one hospital, but across the state. And people were surveyed by a paper-based survey. And there were people who were diagnosed with melanoma either a year ago, some people who were diagnosed 3 years ago, or diagnosed 5 years ago. And in this, we asked about quality of life, we asked about symptom burden, and we asked about unmet needs. And this is some data, and I'll just explain this. I'm not sure whether you can see my arrow, but at the top of the slide are some items. It says EQ5D5L, and this is a quality of life survey, and it asks about 5 questions about mobility, personal care, usual activities, pain or discomfort, and anxiety or depression. And I'm not sure if you can see, but the melanoma survivors, we've got everybody combined, and then people who were 1 year diagnosed a year prior, 3 years prior, or 5 years prior, which has gone a bit wonky and a little bit off to the side. And then there's also a population of the general population. So these are representative of all Australians matched for age and gender, a number of other characteristics. And what we see in the top part of the slide is that for all melanoma survivors, around 30% of people are reporting a level of concern around anxiety and depression. And that's significantly higher than members of the general population at about 21%. In the bottom part of the slide, you'll see a number of self-reported symptoms. And for all melanoma survivors combined, almost 50% of people reporting fear of cancer recurrence. And you'll notice that that's about 53% at 1 year, 43% of people who were diagnosed 3 years prior, and 48% of people who were diagnosed 5 years prior. So large numbers of people reporting the worry about cancer coming back. And below that, worry about cancer spreading, also worries about fear of dying, about a quarter of people. And then other symptoms reported, perhaps by slightly less, but a significant number of people, concerns about memory loss, trouble sleeping, trouble concentrating, always feeling tired, mood swings, etc. So people who are having regular follow-up, many people will be reporting significant symptom issues. This slide shows whether people had all of the information that they needed. And toward the bottom of the slide, you'll see that for all survivors, 56.3%, so a bit over half, saying, I have all the information and advice that I need, implying that almost 50% of survivors, long-term survivors, saying that they had unmet needs for information and advice. And that concerned a number of items, including the physical aspects of living with and after cancer, about 16.3%, and unmet needs around the psychological and emotional aspects of living with and after cancer. In a second study that we published last year, this is looking at, I guess, a novel group of melanoma survivors. So these are people with advanced melanoma or metastatic melanoma being treated with immune checkpoint and BRAF and MEK inhibitors. So immunotherapy like nivolumab, ipilimumab, as well as these targeted therapies like dabrafenib, trametinib, etc. So this was a study that was done at Peter Mac, and it was a pen and paper study as well. And we recruited between about almost 200 people. And we asked about a range of issues that were related to sort of side effects from the medication, but a number of issues that we know can be common in cancer survivors. They're a little bit hard to reckon these diagrams, but all of the bars, the horizontal bars, add to 100%. And the no, or not at all, is in the sort of browny orange. And so the no is always to the left of the 0 line. So I'll just try and explain this. So for people who are on the immune checkpoint inhibitors, so this is people having immunotherapy, we asked, did people have problems with feeling tired? And you'll notice that the not at all group is pretty low. It's probably about 15% of people saying they didn't have problems with feeling tired at all. But maybe about 15 to 20% of people, this was a problem very much. So this dark green, about 20% of people saying this is a problem very much. Maybe 35% of people saying quite a bit. And the remainder of people, perhaps about 40% of people saying, yeah, a little, I was tired to a little extent. Likewise, on the right-hand side, this B, the people having the BRAF and the MEK inhibitors, very large numbers of people saying, yes, I was tired, to varying extents. We asked about other issues that we know are side effects of these agents. So itchy and dry skin, very commonly reported. Most people saying it was a problem a little, but a number of people quite a bit and very much. And again, for people on the BRAF and MEK inhibitors. Similarly, trouble sleeping is again pretty common. Have you felt weak? Commonly reported. Have you had joint aches and pains? Also pretty commonly reported. And again, these are in the majority of people reporting that to some degree. Next on, these are the most prevalent psychological concerns. And so just the first one, how worried are you about what might happen to your melanoma if you stopped treatment? You'll notice that the vast majority of people have a level of concern. So the not at all is pretty low. It would be like 10 or 15% of people in this sort of orangey brown color saying they weren't worried about that. So the majority of people have a level of concern, and for some people it's quite a lot. Similarly, how worried are you about the long-term side effects of these treatments, recognizing that for many of these treatments, they've not been around for very long. And so people do have worries about the long-term side effects, recognizing that there are people who are living with these side effects and they're worried about how they're going to manage with these side effects long-term. The next one is, have you worried whilst waiting for results of medical tests? So sort of scan anxiety or scanxiety is again really common. It's very commonly experienced. And then concerns about, have you felt concerned about conducting outdoor activities which may result in exposure to sun? This is a common worry as well. So perhaps, we've probably got 15% of people very, very worried, and maybe another 20% saying quite a bit, and a large number of people saying a little, and that's true for the different treatments. Similarly, have you had regrets about your exposure to sunshine? Then people report that as a concern also. We specifically asked about a number of fears. We know that fear of cancer recurrence and cancer progression is very common. And again, that was reported in a contemporary group of Australian cancer survivors. Similarly, the worry that my condition might get worse and concerns about dying also. We also asked about lifestyle and functional concerns. So have you had any difficulties carrying out recreational activities like hobbies, pastimes, social pursuits? This seems like a pretty common concern as well. Again, the no group is probably only about 30%. So that implies that the majority of people have this as a concern to some extent. Have you had difficulty carrying out domestic chores is also a concern. Financial difficulties. So in Australia, thankfully, most of the healthcare is covered by Medicare and by the PBS, but still people do have financial difficulties and financial concerns. You'll see that there's a few of this grey area. So this is not answered, or people consider it not applicable, but still some concerns about practical issues like travel and taking holiday. And concerns about work or studying seems like less of a concern, but some people, it is a concern, and it's a concern to quite some extent. So I guess what we'd conclude from this study is that in a group of people with advanced melanoma on newer therapies, but doing well on these newer therapies, they still have quite a lot of physical concerns, psychological concerns, and including worry about cancer recurrence and cancer progression, and general concerns about treatment, what might happen if they stop treatment, as well as scan results. So you'd like to think that we can do better in the healthcare system about identifying these concerns and addressing them, but also we hope that the services that Melanoma Patients Australia offer is an important part of providing that support as well. So building on that, this data, we knew that this was a big concern. We were quite struck by how common it is to worry about cancer progression. And so we did this study that was led by some psychologists at Peter Mac, a study that was done at Peter Mac and also the Alfred Hospital in Melbourne, to adapt a proven therapy called Conquer Fear, which I'm sure Jane will talk about as well, to adapt this for people with advanced melanoma. And we found that this was very acceptable, and it was a stepped care intervention. So some people with low-level concerns were able to access a work booklet that's available online. And many people felt that this was enough and it helped them. And other people participated in a group-based activity or individual consultation with a psychologist. And people valued this and felt that it helped them. So I'm just going to now turn a little bit more to talk about survivorship care in Australia and to reflect a little bit on current practice and perhaps some of the issues with current care and why there's a level of interest in trying to improve care and outcomes for cancer survivors in Australia. So we know that current care in Australia tends to be medically led. It tends to have a large focus on the detection of cancer recurrence and second cancers, with a fairly non-systematic inquiry about current and potential issues, including the ones that we've talked about, psychological issues, but other issues like fatigue, sleep, pain, those sorts of concerns. We know that follow-up can be reassuring. It's good to know that there's no sign of cancer recurrence, It's often pleasant for clinicians. It's good to see people who are doing well, but we know that people leave these consultations with many issues that haven't been discussed, they haven't been identified or addressed. We know that survivors are often report being unprepared for what happens after treatment. They may not be aware of potential health risks. They can often have symptoms and other issues that aren't recognised, and they're not well treated. They're often not aware of strategies that they can do themselves to manage their health and to self-manage. Many people, and I'm sure many people on the call, will say that they have a lot of review appointments and sometimes they're not well coordinated. And for some people, they can travel long distances for these review appointments. We believe that specialist-led review appointments may not be the best use of specialist time. They may be able to see new patients and people who are having issues that need a specialist review. GPs tell us that they're often prepared to be involved in the care of cancer survivors. They're already seeing survivors to look after their other health concerns, but they're often not given the information and the support that they need to provide survivorship care. We know too that other services are sometimes underutilised. That could be rehab or survivors services provided by NGOs and not-for-profits like MPA. There's underuse too of nursing and allied health services that could be in the oncology setting, but they could be in the community as well. And we have, I guess at the healthcare level, limited measures of what is good survivorship care. And we're trying to improve that and work with a number of organisations. So we do have measures of what is quality care and that we're collecting that data and reporting it. So because of these issues in current survivorship care, there's a lot of work going on to try and improve care. And in Australia, COSA, which is the Clinical Oncology Society of Australia, a few years ago developed this model of survivorship care, which we're trying to implement more broadly. And we published about this earlier this year, and the COSA model is available online at the COSA website. And based on this, there's been quite a lot of work. Additionally, Cancer Australia, which is the peak government agency, has also developed principles of good quality survivorship care. And in Victoria, at least, there's been quite a lot of funding to develop new models of care to better support survivors and better meet survivors' needs. And quite a lot of funding's gone into that, and survivorship is embedded in our cancer plan, which is great. Additionally, in Victoria, the Australian Cancer Survivorship Centre was funded about a bit over 10 years ago. I'll just talk about that on the next slide. So we're based at Peter Mac in Parkville. And as I mentioned, we've had funding for over 10 years from the Victorian government, from Peter Mac, and for much of that time also from philanthropy. We had our official launch over 10 years, just 10 years ago, so this is our 10-year anniversary. And that funding supports a small staff. And we have a dual focus on Peter Mac because of Peter Mac and the Parkville precinct because of the funding from Peter Mac, and also more broadly on a focus on trying to improve outcomes for survivors in Victoria. But our reach is far broader than that because much of what we do to improve care and outcomes for survivors in Victoria extends to a national remit also. We actually don't provide direct clinical services, so we don't run clinics or services, but we work with a broad range of stakeholders to try and support and enable improved care. And we're largely about service delivery more than research, but we certainly do undertake research and support research activity. And on the left-hand side of this slide, we have three broad areas of activity that I'll talk about briefly: trying to provide information and support for survivors, education and training for health professionals, and providing leadership and guidance. And our goal is optimal outcomes for survivors and for carers. So with respect to information and support, we've developed quite a lot of fact sheets, including developing new information in 8 other languages. We have done our own podcasts and webinars. We are really keen to support others doing webinars, including this one. We've also developed some videos, including in other languages, as well as audio resources. And I'll show you our web address on the last slide, so you'll have that. We've developed information and support fact sheets, so that this is an example of emotional impact of cancer and treatment, a fact sheet for survivors, and the one on the right-hand side is a question prompt list. So to encourage people to, maybe these are questions that you might like to ask your healthcare team as well. We also have developed a number of survivor stories, and these were developed by Meg Rinderman, who is a cancer survivor herself and also a volunteer with ACSC. And the one that I've got here is Alison's story, Alison Button-Sloan, who you will all know. So we're really pleased that she shared her story as well. And so these are all available on our website. We have developed information and support for specific groups, and working with the Youth Cancer Advisory Board, we've got resources specific for adolescents and young adults. And we've developed quite a number of resources in print, audio, and video in other languages, including in Chinese. We also have a common survivorship issues directory, and I hope that this might be of interest to many people on the call. It's available at the address pdmac.org/servedirect, and you'll notice a number of issues here that are common to people regardless of the cancer type. So you'll notice ones around, say, for example, anxiety and depression, fatigue, fear of cancer recurrence, financial toxicity, returning to work or study, sleep, sex and intimacy. And for each of these issues, I'll just show on the next slide, there are a number of sections. So we developed this as a directory of services at Peter Mac and more broadly, but also to provide a place where we have guidance documents, information for cancer survivors and their families, as well as additional resources where they're available for health professionals and particular projects. So some examples here for fear of cancer recurrence or progression, and also for fatigue. So again, it's at pdmac.org/servedirect. So hopefully that's of use to people on the call. We also know that self-management and taking an active role in your own healthcare can improve quality of life. It can help people to feel more in control. It can also reduce the impact of issues that people might be experiencing on their day-to-day life. And it can also help people to get back into the activities that you enjoy and that can give people a sense of fulfillment. It can also help people to get back to work and study. So ACSC have developed a number of resources to support people to manage their own symptoms, manage their own health, and they're available on our website too. So we hope that they might be useful as well. With Cancer Council Victoria, we run a program called Cancer Wellness. And this year we've struggled to do that face-to-face. So we've developed a number of videos to help people with a number of issues that are listed here, and they're again available on our website that we hope will be useful to survivors regardless of their own cancer experience. I mentioned that we do quite a lot around education and training for health professionals. When we started over 10 years ago, we asked health professionals in the cancer setting and in the community, do you feel that survivorship care is part of what you do? And everyone said yes. And we asked them, do you think that you have all the education and training you need? And everyone said no. And so we've developed a number of resources, which include fact sheets and guidance documents for people in the cancer setting as well as in general practice. And we've developed a number of training opportunities, which could be face-to-face, workshops, conferences, as well as online training. And this week we'll launch the refresh of our training that we host through EVIQ Education in New South Wales. So there'll be an announcement about that coming up this week. And that's free and available to anyone. Finally, on survivorship leadership and guidance, we at ACSC, we contribute to state, national and international guidance and policy documents. We provide input into national and international survivorship committees, including in Australia, the Clinical Oncology Society of Australia, internationally, the American Society of Clinical Oncology, or ASCO, and the International Psycho-Oncology Society, which is called, the acronym is IPOS. We also convene a survivorship community of practice that brings together people working on survivorship projects to share their experience and troubleshoot problems and concerns. We have a clinical champions forum as well, and a research forum. We also co-convene a biannual survivorship conference that was held most recently in March, which was probably the last face-to-face meeting that we've had, which we quickly went to virtual as well as face-to-face. And we also provide support to everybody who's doing the work in survivorship. So on new models of care, on new support services, as well as research projects. So we can't do this all ourselves, but we're really keen to support other people and to enable that work. So finally, I'll finish up with some contact details. So if you'd like to join our emailing list, we don't spam people, but do like to share our work and the work of others. You can do that by emailing contact@acsc@petermac.org. If you'd like to, you can email me on my address listed there, michael.jefford@petermac.org. The ACSC website is at petermac.org/cancer survivorship. And if you'd like to follow us on Twitter or on LinkedIn, then you'll see our contact details there. So I hope that that's of some value. I'll leave it there. Happy to take questions. Perhaps I'm not sure whether it's now or after Jane's presentation, but yeah, leave it there and hope that's of some interest. Thank you.
Thanks, Michael. That was a really in-depth presentation, and I can vouch for the work that the Survivorship Centre does, being a melanoma patient myself and having gone there. So, on to our next speaker, Professor Jane Turner. Professor Turner is a consultation liaison psychiatrist who has worked clinically for 25 years in psycho-oncology. Sorry, Michael, I just saw you with the dog in the snow. Sorry, Jane. Professor Turner treats patients with diverse cancer diagnoses and disease stages. Jane has been extensively involved in educational initiatives to enhance this confidence and skills of health professionals in providing psychosocial care for people with cancer. Her research interests include the evaluation of innovative models of psychosocial care provided by frontline health professionals and the promotion of wellness for cancer survivors. She was a member of the Clinical Oncology Society of Australia working group that developed the COSA model of survivorship care, which was launched in 2016. Jane was an investigator in a multi-site trial of a manual-based psychosocial intervention for patients with breast, colorectal cancer and melanoma with high fear of cancer recurrence. I'd also like to point out that Professor Turner sits on MPA's Medical Advisory Committee. So welcome, Jane, and over to you. Thank you.
Thank you so much. It's wonderful to be with you tonight. I'm delighted to be able to share some information. So Michael has provided a very broad context and overview about survivorship issues, and I'm going to drill down and talk about one of the really big ticket items. You saw in the data he presented how common fear of cancer recurrence is. So when we think about this, what do we mean? Well, the definition we would usually use is developed by Sophie Labelle from Canada, and she talks about the fear, concern or worry that cancer could return or progress. So this is really a term not just for people with early cancer, but it also applies for people who may have metastatic cancer. Now, how extensive is this problem? So Michael's data is more up to date than this data that I'm presenting to you now. And he indicated that this affects a large number of people. But this is Australian data, and it was across prostate, lung, colorectal, breast and melanoma cancers. And they used a really nice structured measure to determine people's unmet needs. 37% of survivors reported moderate or high levels of unmet need in relation to one or more items. But here we are, number 2 was fears about the cancer spreading. So this is actually a significant issue for a lot of people who've had cancer. And it is absolutely not trivial. I know that often we think about biological concerns and physical symptoms as being the big ticket items that people worry about, and psychological concerns are perhaps soft issues, but this is absolutely not the case. So FCR, fear of cancer recurrence, is associated with worse quality of life. People with high FCR have distress and anxiety, and they're often preoccupied with the cancer. And more than that, it holds them back. People often stay stuck. They can't establish future goals and plans. And patients say to me, well, why would I bother getting fit? Why would I bother losing weight? I'm sure the cancer is going to come back and I'm going to die anyway. So we also know that people with high fear of cancer recurrence really form a spectrum. Some people avoid follow-up, they miss appointments, and other people are really preoccupied with checking, looking at their skin repeatedly, things like that. For most of the work that's been done in this area is with breast cancer, and Belinda Thew's work looked at women with breast cancer. I certainly saw women in our study who were examining their breasts 35 times a day. As I said, avoidance of screening and monitoring. And you will recall from Michael's slides that fear of cancer recurrence appears to persist over time. This isn't something that you have and every year you think, oh, well, it hasn't come back, I'm feeling a lot better, that's great. This does persist over time. Now, here we are. Here's a slide from the Australian Cancer Survivorship Centre. But if you look on Cancer Australia, BCNA, ovarian cancer, this is actually becoming a really crowded space. People are recognising that this is actually a big issue. But paradoxically, that may not be very helpful because it means that you don't really know which is the best source of support or information. And it may be that there's variation in the sort of information you get. So I would say with fear of cancer recurrence, one of the big things we're aware of is that traditional help may not be the best option. So when we see people with anxiety or depression, often we would advocate cognitive behaviour therapy. So in CBT, you're aiming to identify unhelpful thoughts and behaviours. Oh, I know it's going to come back, therefore I shouldn't do this. Well, how do you know it's going to come back? And so you help people to develop the skills to challenge those cognitive distortions. The problem with applying CBT to fear of cancer recurrence is, in fact, the clinical reality is that there is uncertainty about prognosis. And I think for patients with melanoma in particular, one of the big challenges is immunotherapy. It seems like, you know, the magic ticket that has resulted in many people being incredibly well. However, these treatments haven't been around for a huge amount of time. And a lot of people say to me, I worry that the bubble will burst. I worry that somehow down the track we'll find that they're not the promise that we were hoping for. The other problem with CBT is it's really focusing on the here and now, and it doesn't really help the person understand how they came to that point. And it also doesn't help the person respond to existential challenges. So if you recall going back to some of Michael's slides, he talked about fear of dying, those sorts of issues, and CBT does not help people to deal with that. So rather than presenting a lot of data about our study, I'm going to focus on some very practical suggestions. Michael's already provided the background data and information. I'm going to suggest what you might do if these are issues for you. So when we did this study that Michael referred to, Conquer Fear, we developed a, if you like, a formulation where part of the intervention was trying to track why this person developed this high fear of cancer recurrence. We call it the journey. I don't like that term, but that's the term that's commonly used. But what we found was that when people could understand how they came to that point, it was really reassuring. People could say, oh, I'm not crazy. No wonder I feel so anxious. So the circumstances of the diagnosis, we hear repeatedly that people have had a spot or a concern and been reassured, or they've been told it wasn't too bad, come back next year. If you've had a diagnosis of melanoma and you feel that initially it's been missed, well, that raises your anxiety and you worry that things mightn't go well in the future. Again, experiences of treatment. Some people will have an excision of a lesion and it will heal beautifully. Other people might have excision and develop lymphedema. They might develop a seroma. Treatments can be variously toxic or very well tolerated. So if everything seems to go wrong with your treatment, of course, that will actually heighten your anxiety and concern about the future. And then, of course, expectations about completion of treatment. And a lot of people think, oh, finished treatment, that will be fantastic. I'm so excited. And then suddenly people find that they're isolated. They don't have that close support. All of the social support people have had while they're having treatment evaporates. You know, people are stopping to do things. And there is often an expectation that you will get back to normal. And, you know, I've got here some examples of reactions of others. And so there's often this covert or overt expectation, well, you should pull your socks up now, you finished this, you don't look sick. Or conversely, people will tell you terrible stuff that makes you feel sick with anxiety. Oh, my aunt had cancer, she was dead in a month. For people who are having immunotherapy, there's that whole, are you still having treatment? Or one of my least favourite messages is you've got to keep positive. If you want to survive, you've got to be positive, and there's no evidence that that's the case. Or conversely, people who are actually telling you to take a whole pile of vitamins and herbs. So you have someone who might have had a diagnosis that they felt was missed, the treatment's been hard, trying to finish, and then there's pressure from people to be positive, to be brave, no opportunity really to talk about what has happened to them. So what I imagine is that for many people, the journey, and I use that word advisedly, has been rough. You know, you walk along and you trip and you stumble. And so unsurprisingly, by the time you finish the treatment, your tank's empty. You're running on empty. You've just been on automatic pilot. You've tried to survive it. How do you move on from here? So I've said that CBT isn't particularly helpful. And here is the different approach that we used in our study that was very effective. The first thing is to say fear of cancer recurrence is a rational fear. It's not stupid, it's not dumb, it's not irrational, it is rational. Reassurance doesn't make it better. Now, I know a lot of people think, well, if I have that extra scan, I have that extra test, that will reassure me. Well, no, it doesn't. It actually probably makes anxiety worse. Being urged to be positive really inhibits your ability to talk about what's stressful. And we know that being able to talk about what troubles and worries you is actually helpful. I'm a psychiatrist and I spend my day listening to people talk. And sometimes just having someone who listens and who acknowledges is very powerful. But a lot of people in the community don't get that because people are too busy telling them to be positive. Don't expect that it will reduce over time, but if you can understand how you came to this point, that's probably actually going to be helpful. Then you can make sense of it and perhaps be less critical and less judgmental of yourself. The other thing I would say, oh, look, those are the days where we could actually travel on a plane, but we won't go there. So most of us come to a diagnosis of melanoma or any serious illness with baggage. Okay, we've got baggage, we've got family histories, we've had broken relationships, we've had financial strain. And for many of us, it's not the easy collection, that's my bag, that's my bag. Many of us have actually coped by trying to deny, avoid, minimize, and just assume we can trudge through life without ever dealing with it. And I think the diagnosis of a serious illness really, as one patient said to me, holds a mirror up where you're forced to look at who you are and what you are. And this might be actually an important part of the approach to think about what matters to you. And I'll explain in more detail in a minute. So what we're saying is worries are unlikely to be completely eliminated, but there are practical things that can help you focus less on them and develop goals for the future, which give your life purpose, direction, and meaning. Okay, so the first thing is the new normal. You were driving, if you'll indulge me with this metaphor, you were driving, minding your own business. Cancer, this unwelcome guest, melanoma, hopped into the back seat of your car. Do you actually turn around repeatedly and say, get out, get out, get out? Well, you risk not being able to see where you're going. You risk running into the car in front of you. And I can tell you now, this guy's not getting out. The way to think about it is to say, this is the unwelcome passenger. I didn't invite him in. However, I can continue driving. I can continue living my life. I might look in the rear vision mirror occasionally and think, oh, you're still there, you mongrel, but keeping on driving. So that's a huge culture shift, as opposed to thinking, I've got to stop thinking about it. The next thing I would suggest is learning about handling worry. One of the things we did in our study was to teach people detached mindfulness. So in detached mindfulness, you develop awareness of a thought, but you do nothing about it. Now, I explain this to people by saying, if you woke up, say, one morning and there was a red sports car parked outside your house, would you get in it and go for a drive? Well, unless you're a psychopath, probably you wouldn't. Would you fill it with petrol? No. Would you take it for a service? No. And I say to people, why not? And they say, well, it's not my car. So in exactly the same way that you can look at the car, see it's there, but not do anything about it, you can do that with your thoughts. I worry that this will come back, but you can look at the thought and you can say to yourself, well, of course I will worry from time to time. That's normal. By actually allowing yourself to see the thought and not try to push it away, it actually reduces its intensity. Another thing we did was attention training. Now, this is a specialised technique developed by Adrian Wells, but a lot of psychologists are able to deliver this. And essentially the aim was to help people be better aware of the way their attention was focusing, be better aware of where their mind was going, and learn that they could exert control over that. You know, we often have thoughts that take us down the rabbit hole. Well, we're the boss of our thoughts. And in fact, one of the patients in our pilot study said, I have learned that I do not have to be the passive recipient of my own thoughts, which I thought was fantastic. The other thing that can be helpful is something like acceptance and commitment therapy. Now, when I first heard about this, I thought, oh, what do you mean, suck it up therapy? But in fact, what it is actually doing is helping people focus on what is changeable and what is not. Often we bash our head against a brick wall trying to change things that are actually not changeable. So in this therapy, which has been demonstrated to be very helpful for people with anxiety and depression, we're actually saying, okay, what can you change? What can you modify or adapt in your life? And how can you work on that? So it's about goals and values. What matters to me? What do I want for my future? And we do a card sort exercise. This is something you will find if you just Google this name. And what we do is we give people cards. Okay, now this is just some examples. There is actually quite a few of them, and we have little pieces of cardboard. And you say to the person, okay, here's this card. I want you to say, put it in 3 piles. This is really important. This is not at all important. Maybe in the middle. And then what we do is we actually look at all of the things that are not important. And often people will say, you know, that I said that wasn't important, and yet I spend a lot of time focusing on those things. That's a waste of my time. We then look at the things that people say are important, and we say, well, if these are things that are important to you, if these are values, how can you set goals around them? What can you do? And in fact, our next two speakers will actually provide really, really helpful examples of how you might achieve some goals in some particular areas, particularly with physical health and well-being. We also use metacognitive therapy, and without being too, this is actually part of what we call the third wave of psychotherapies. It's really, again, about the philosophy of the thoughts aren't the problem. Worrying about the cancer is not the problem. It's what you do with it. And so if you actually say, well, I've got to be on my guard, you know, if it comes back, then I'm prepared. Well, how does that help? What does that do for you? So parts of this are the attention training, parts of it are the detached mindfulness, observing thoughts without reacting to them. We ask people, how do you know that this is harmful? How long have you been worrying about it? Does worry actually help you? How would that cause progression? And then one of the things that we do in this study, which has been very helpful, is clarifying goals of follow-up. You heard Michael say that often those goals aren't articulated. And I think until fairly recently, health professionals have been really fairly poor at being able to say what people can do to be well. How can you actually get information about lifestyle issues? And that's what you're going to hear now. How can you cope with surveillance? How to respond to new symptoms. So every time you have a sore back, if you go immediately to the GP and they panic and organise a scan, that actually reinforces anxiety. Learning about how to respond to being able to say, well, have I ever had a sore back before? Yes, I have. Could it be because I've been gardening? If it was the melanoma coming back, would it go away by tomorrow or go away with Panadol? Probably not. So if new symptoms are very severe, cause you terrible distress and they persist, yes, you need to get them assessed. But learning ways to respond to those rather than panicking and seeking urgent intervention. And I would ask all of you, is Google really your friend? And you can tell by the way I've asked that I suspect it may not be. That's why you need to get reputable information. Threat monitoring is important. We know that if we don't pay attention when we're crossing the road, we'll walk out and get hit by a bus. We need to be aware of risks. The problem is once you've had melanoma or any serious illness, you're hypersensitive. We often look for danger. And it's actually not always helpful to be oversensitive or over-checking. And again, it's about accepting some degree of uncertainty. Developing body awareness, learning how your body functions, learning what symptoms are serious, learning when you need to have things checked out. Questions to ask yourself. So do I worry? Probably most people listening to this would say yes. How often do I think about it? But then the next thing is, how much does this affect my quality of life? And do you want help with that? In which case you should probably seek help. There are some really detailed structured measures to assess fear of cancer recurrence. But just recently a publication has looked at this single item. And it says, you know, on a scale of 0, you know, if 0 is the least possible fear and 100 is the worst, where would you put yourself? And if you're saying your level of fear of recurrence is 45, I would encourage you to actually talk to a health professional about that, to a GP, and perhaps look at a referral for some treatment with a psychologist. And I just want to also mention anxiety and depression. So fear of cancer recurrence is not the same necessarily as anxiety and depression. There are some features in common. But we do know that anyone who's had a serious illness of any kind is more likely to get depressed. And, you know, the difference between depression and just feeling down, fed up, is that the mood tends to be sustained over time. It occurs most days. Things become a bother. You don't feel optimistic about the future. And, you know, I've just got this very, very simple view. Where do you fit on this line? And if you're fitting on the side much more towards the unhappy side, don't put up with that. Go and talk to your GP. We have very effective treatments for anxiety and depression. They don't automatically involve medication. And then, of course, and I am going to finish up here, but really the hard question about fear of cancer recurrence. You know, we've talked a bit about what it means, what would it mean physically, financially, how would that affect your future goals and planning? But the really hard question is, what would that mean for me and those I love? And most of us want to avoid that question, but paradoxically, thinking about it and talking about it may reduce anxiety. And so Sophie Lebel's group I mentioned before, this is just a very small number, but she talked about it when I was at a conference last year, and it really struck me as so powerful. So in this session, people were asked, can you write out your worst case scenario? What is the worst possible thing that can happen? And I can imagine many of you thinking, oh, I couldn't do that, I couldn't do that. But in fact, what they got people to do then was to look at it every day in homework, to look at that. And then they rated their anxiety before and afterwards. And in fact, what happened was that people who actually did that and looked at it found their anxiety reduced. It was actually putting it out there. It wasn't unknown. And again, acknowledging that that fear is okay and that's something that has to be worked through in your life. So in summary, what I would say is that fear of progression is common, or fear of recurrence. It doesn't just go away. It affects a whole pile of things, quality of life and relationships. It makes sometimes people feel stuck. It stops people from getting ahead in their life. The well-meaning reassurance that people often offer you is not helpful. Being able to talk about it is actually helpful. Having a lot of unscheduled tests is not likely to be helpful. And really the way forward is negotiating that new normal. So I can't outrun this. I can't evict this unwelcome passenger. How do I navigate the world? How do I keep driving whilst acknowledging that they're there? And that is really almost the opposite of what most of us would normally do when confronted with this sort of situation. I think it is really important to recognise triggers. You've heard Michael talk about scanxiety. So what are the triggers? When are you vulnerable? What supports and safety nets can you have? Think about the things that are helpful and not. Now, when COVID was kicking up, my resting pulse was probably 120. I was really, really anxious about it. And I found myself looking at ABC News, COVID updates, probably every 2 or 3 minutes. I mean, really, was that helpful? No. And I've had to stop doing it. So finding things that are helpful, identifying things that are not helpful, and recognise that there are specific therapies that can be provided for fear of cancer recurrence, for anxiety and depression, and it's too important to suffer in silence. So I'll hand back now to Alison, who I think might be going to address questions.
Jane, that was a fabulous presentation. You've answered some of my questions and acknowledged some of my fears. So we have been monitoring some questions, and I did bring some with me from our closed support group, which has nearly 2,000 people. And a common thing that people kind of skirt around, and I don't know whether Michael or Jane, this question, which one of you want to answer it, but it seems to be the elephant in the room in terms with people's sexuality when they're finished cancer treatment, and they often don't know what to say, what to ask. And especially I think for older people, because younger people don't think that older people have sex. And if you're an older person and you've had, this cancer therapy.
Oh my God, that's a shock.
I know, but I'm talking about the elephant in the room, and I'm just not.
I actually have a little elephant. I use that when I'm teaching medical students. I have an elephant in the room.
I'm pleased you're acknowledging it, Jane. Jane, do you want to go ahead?
Yeah, look, I think sexuality is a really important issue, and probably related to that also is the issue of fertility. And, you know, I see people who really struggle with both of those. I'll talk about fertility first. A lot of doctors make an assumption that if you've got a serious illness, particularly if you've got metastatic disease, that you wouldn't want to have children. But in fact, the data very strongly says that people who have a serious illness don't usually change their ideas and plans about childbearing. And I think that people have to be very clear in saying to their doctor what their values are and what's important to them. I think changes about sexuality. Our brain is our most important sexual organ, and a lot of the treatments we have do have physical changes, but really communication is fundamental. And I think that, I'm not sure if you've got prompt sheets for this, Michael, for people to actually ask their health professional, but I think, you know, we're all sexual human beings, and I think we're entitled to ask about that and have our questions answered. The fundamental thing, I think, to begin with is actually establishing lines of communication. So easy to misinterpret. He doesn't, or he or she or whatever, partner doesn't actually approach the patient because they've just had surgery, doesn't want to make them sore, tender, whatever. Person who's had the surgery says, oh, see, that partner isn't interested. Really a lot of chances for misinterpretation and communication issues. There is an Australian Society of Sex Therapists, and you can find that online. They're highly qualified people. A lot of GPs may be interested but not have the time or expertise. So we have to put it on the table, absolutely.
Thank you. Michael, would you like to add anything?
I think in the interest of time for the next speakers as well, I'll be very brief. But I guess to highlight that our Common Issues Directory has fertility and sexuality as separate topics. So they are included there. So petermac.org/serve-direct. And I'm sure that the new melanoma support nurse would also have links to services, information and services as well.
All right. Thank you very much. All right, Jane and Michael, thank you. I will move on to the two next guest speakers, if I may. So I'll just turn over now. We now have Ms. Jane Freeman, and Jane is an internationally regarded accredited practicing dietitian, nutritionist, IOC qualified sports dietitian who specialises in advising individuals on the best dietary approaches to help support their cancer treatment and other health needs. She is known for her creative diet strategies to help manage side effects, including appetite, weight, and bowel function challenges. Jane also inspires with good food ideas and is a professionally trained cook and is the published author of How to Eat Well When You Have Cancer. This was in a highly acclaimed book by cancer patient support groups and has been awarded a British Medical Association Book Prize. Jane is a consultant at the Melanoma Institute Australia. Welcome, Jane, and over to you. Thank you.
Thanks, Alison. Well, I'm feeling quite hungry, so I am going to invite you all into my kitchen. Stay with me. Sorry, it's not to see. Can you see that okay?
No, Jane, I can't see anything.
No? Okay.
If you go to the bottom where it says share screen. Do you have your PowerPoint
Yeah, I'm
already
pressing
open?
share screen. Is that not coming up, is it?
No, it's not. You're not sharing it. Oh, here we go.
Got it now? Sorry, I'm a bit slow. There we go. Is that working? Okay. Is that working? Yeah.
Yes.
Great. Hang on a second. All right. So as I said, I'm feeling quite hungry, so I'm going to invite you into my kitchen. And whilst I'll go through, you know, sort of good eating recommendations for, you know, preventing and also living well with cancer, I really also hope at the end of my talk this evening that you'll know what to put on your plate and hopefully feel a bit inspired to try something new or add something a bit greener on your plate or something, you know, something else that's going to really lift those taste buds. So I'll start with just reiterating, you know, what eating well can really help with. The first is, I guess, you know, most importantly, as you're embarking on the sort of stress of cancer treatment, which of course can include a myriad of surgery or chemotherapy or radiotherapy or immunotherapy, whatnot. You know, they put a lot of stress on the body. So the most important thing your diet can do is keep you strong and well and just able to tolerate the best dose of treatment. It's going to help with, you know, your immune system's key to fighting cancer as well, so it helps to ensure that's working the best it can. Helps you feel better, gives you energy, enables you to get on with just doing. Another really important flag is most people through cancer treatment and beyond will lose muscle and strength, which can contribute to sort of, you know, problems with compromised nutrition or what we call sarcopenia, which is now a big flag for people going through cancer treatment, loss of muscle, and it has been shown to sort of, you know, correlate a bit to how well they do through the treatment. There's emerging evidence that diet, of course, can help reduce risks of recurrence or other types of cancer, and, you know, helps with the big picture. I guess we understandably can be a bit myopic when we're going through cancer treatment, but we've got to also remember our other health and fitness needs, which your diet can help with. So the starting point, you know, regardless, is just really eating well requires a good, adequate intake of food nutrients, energy, protein, carbohydrates, healthy fats, vitamins and minerals, and plus a good dose of some of the what we call phytonutrients, nutrients that help to protect and look after our cells. And I really like this chart because I think it gives a really good summary and reminder of, you know, the good old food groups that are outlined in our Australian dietary guidelines. 4 to 6 serves or more if you're active of whole grain cereal foods. And I like the serves in this because it reminds you, people are often quite scared of carbohydrates and should I cut them out? And I guess, absolutely, I'm going to talk a little bit more about why this group is really important in the diet, but it's also about portions and the amount you need. It might be a cup of rice or a couple of slices of toast, for example, not necessarily the buckets. Of course, it's including lots of good fruits and vegetables in the diet, at least 5 serves. Veg, lots of colours, and a couple of serves of fruit. And interestingly, you know, Australian dietary surveys have looked at, you know, Australian intakes of this food, of these 2 food groups, and it's pretty depressingly low when people self-report how much, how close they come to meeting these recommendations. It's only about 10% in total manage to get the 5 veg and 2 bits of fruit in a day. It's having.
Excuse me, Jane.
Yeah.
Could you just maximise your screen, please? We can't quite see the pictures that well.
Okay.
That would be fantastic. Thank you. And sorry.
That's okay. I thought it was maximised, but it's not, is it? Can you see the whole screen or?
No, I can see your notes onto the side. You've got the next slide. Yeah.
Okay, hang on. I think it's.
There should be a little bar down the bottom on your PowerPoint that makes it enlarged. See down on the right-hand side, down the bottom?
Yeah, sorry, I'm just getting one. Apologies. I'm trying to work with two screens and I think it's
Oh, perfect. Oh, no, you just had it.
gone back. Does that work better?
No.
No. All right.
Well,
Well, listen, I mean,
let's
what
just
I'll...
continue. Yep. Oh, no, there you are. Perfect.
It's better. Yeah, I don't know why that's doing that. I think it's the problem of working with the two screens. Is that better or not? Let's lost it again.
No, it's just the same. Perhaps just
All right,
continue
I'll leave
on,
it.
Jane. I'm sorry
Yeah,
for
sorry.
interrupting
No, I'm
you.
sorry. I don't know why it's doing that. That's better, that one, is it? But you have the other bits in there.
Yeah.
All right. Well, listen, I can share links to this chart. So if it's hard to see, you can look at it later. Apologies for that. So anyway, just getting back to talking about protein. This is a time where there's a lot of work going on behind the scenes in the body, cell repair, tissue repair, as I mentioned, loss of muscle and whatnot. So this is really an important food group to try and include, you know, enough of across the day. And I'll talk a little bit specifically about that. It's including enough dairy or dairy alternates, which are important to provide our calcium needs. It's also some healthy fats, and it's also, you know, occasional treat foods and, you know, trying to cut and avoid, limit your alcohol intake. So on the protein, is that visible? Sorry, Alison.
Sorry, I just had to unmute. Look, it is better. It's still
It's not
small
great.
though. But look, if this is how it has to be, that's okay. Jane, I'd much rather hear you talk and...
Yeah, all right. Let me push on and apologise for the slide.
No, don't worry.
So I'm just flagging protein again because we've just, Michael mentioned COSA recommendations. There have been some recent recommendations for protein intakes around cancer treatment. And in fact, the amount has increased from recommended sort of RDAs for generalist populations about 0.8. For people going through treatment, you need to sort of have a bit more protein. So almost like 1 to 1.5 times, and in some cases double or a bit more protein to what's normally recommended in a healthy diet. And so to do that, you really have to sort of just get your head a little bit around making sure that each of your main meals and snacks includes a bit of some eggs, some milk, some chicken, handful of nuts, tuna, maybe some pulses and beans or tofu as well. So each meal should be really framed around some of these foods that are going to do a lot more of the work that we need that's going on in the body. And then around that, of course, there are guidelines. I'm having so many problems with my slides here. That have been distilled by leading research organisations that have looked into the role of dietary intake and body weight and level of physical activity and how it may be able to help reduce the risk of cancer. And that's both an initial and possibly a sort of secondary or recurrence type of cancer. So just in a sort of nutshell, the guidelines that have been distilled, and these have got a lot of research and evidence behind. They go through each 10 years, summarise over 7,000 scientific papers to be able to sort of come up with these recommendations. It's to do your best to stay at a healthy weight. It's to be physically active. It's to eat a predominantly plant-based diet, which is rich in whole grains, vegetables, fruits and cereals. It's to limit the sort of ultra-processed foods, you know, the ones in the supermarket that have got lots of colours and different patterns on boxes and whatnot. It's also to look at limiting consumption of red meat and processed meat, but that doesn't necessarily mean you have to totally cut it out. They're recommending about sort of between 450 to 500 grams of cooked red meat a week that I would suggest could be dosed into sort of 100 to 150 gram serves a couple of times a week in the course of a week. It's limiting sugary drinks. It's limiting alcohol consumption. And they have also looked extensively at the role supplements may play in cancer prevention. And to date, they have found no sort of strong or suggestive evidence that taking supplements over and above eating a good, healthy, well-balanced diet adds any benefit. And in some instances, supplements can cause harm. And there's a number of studies that have been quickly stopped because the group having all the beta-carotene supplements have ended up having sort of higher levels of morbidity and mortality than the group that are on the controls. Also 10 years ago, you know, fortunately or unfortunately now, we've got a lot more people living with cancer. So they've been able to really research people who've already had a cancer to sort of look into their diet and see if there's anything specific or additional that they should be doing post-cancer treatment. And at this point in time, they're recommending to try and follow these general cancer prevention recommendations if you can. So just another sort of little one that's I think is quite relevant, of course, to melanoma, and that is just talking a little bit about bowel function and how, again, modulating your diet, specifically your fibre, can kind of help with that. Fibre is something people get a little bit confused about. They're always sort of aware that eating lots of fruits and vegetables are good to help boost our fibre, but often overlook the need to also include what I call the sort of cement type of fibre. It's the insoluble fibre, the grains. You can see hopefully see my whole grain bits of bread in there, the brown rice, the cereals. And that's the type of fibre that really does add the bulk and the real volume of food that adds fibre in the diet. The benefits of adding fibre is, of course, it keeps your bowels regular. And often there's medications and whatnot that can be slowing those bowels down. But there's also been some preliminary data in patients who have been on sort of checkpoint therapies that, in fact, those patients that had a really high fibre diet, not only did they have a much more diverse gut microbiome, but in fact they were about 5 times more likely to respond positively to their immunotherapy treatments. Now, of course, as those on immunotherapy will know, lurking around the corner can be some bowel function problems like diarrhea and potentially colitis. So what I would say is that you really start with a good high fibre diet, but of course if those symptoms do start to present, then you will need to pull back on the fibre and sometimes go on what we call quite a low fibre diet to help deal with that diarrhea, but certainly it is a good place to start. It doesn't have to be cordon bleu cooking, so I've just put up there my, basic sort of buttered chicken that, I think I bought somewhere like, a supermarket and whatnot. But what I really encourage you to do is think about when you're making these kind of meals, can you add some extras in? So there's a can of chickpeas, there's some cauliflower, I've served it with brown rice, I've thrown a handful of greens in there. Another favorite is, just getting some of those frozen fruits and making them up as a smoothie. If you're having a snack, think about a whole grain cracker with peanut butter. This is my Wheat Bix slice, which is delicious. I've got a 17-year-old son who, of course, is a sugar fiend, and so if I do make a pudding or whatever, he's always like, "Mum, you've put a banana or something in this." But again, it's just that idea of what can you do to tweak your meals just to sort of add more goodness, nourishment, fibre, other food nutrients into it. Times, of course, there will be difficulties eating, possibly absorbing your food, and what I'd say at those times is remember that a nutritionally adequate diet, supportive diet is the #1 priority. So if you are having difficulties, you're losing weight, you're potentially putting yourself on the back foot and therefore, at risk at not being able to tolerate your treatment. So it's really important if you're struggling a little bit with your food, you've lost your way, that you do talk to your treatment team to get some advice. Maybe there's some medications you can take if you're feeling nauseous or you have a bit of diarrhea, for example. Really put your hand up sooner rather than later. My heart sinks when someone walks into my office and they tell me, they've lost 10 kilos, 15 kilos because they've been having trouble along the way with their food and eating, because, you know, it's often harder to regain all that muscle and energy lost when, you know, we're that far down the track. It's easier to sort of jump on these sort of and troubleshoot troubles with eating or tolerating food sooner rather than later. We all live in a world of a very contrived, strange nutrition world where there's a lot of, obviously, every which way you look out there, there's a new diet book, there's a new claim, and when that comes to cancer, it can be even more confusing. There's so many different, you know, opinions and options to sort of go for. And I know Jane mentioned Google. Google's not your friend when it comes to diet research normally. So I just really sort of, I guess, put this slide up just to sort of wave the flag, the red flag. Please be as cynical as I've become over my many years as working as a dietitian of the halo claims, the natural, the plant-based, the organic, the superfood, the fat burning, the promise of a cure, the testimonial that, you know, this is the best thing ever since sliced bread, meaningless jargon. Just always really sort of think, you know, find out who's recommending it. And I do really encourage you to, again, just check in with your treatment team, your nurse, you know, doctor before you sign up or sort of start on some, you know, really restricted dietary approach. Nutrition is not meant to be some sort of arcane type, you know, medicine or miracle. It's meant to support us, nourish us, keep us strong and able to really kind of be able to tolerate and live life well, tolerate our treatments and live well. And this, I guess, is the most important part. I guess we all know, you know, what we should do most of the time, but often it's hard to actually manage to do it. We all struggle with that, with being busy, tired, time. So I'm just going to talk you through my, you know, quick sort of basic steps to sort of cross off each week to try and improve, you know, what you're able to manage to get on the plate through the week. First is just starting with maybe a bit of a menu plan. I'm in the process of developing what I'm calling Can Cook, which are some weekly menus just to help people get a few starter ideas of meals that really do combine the cancer recommended guidelines. But it's then sort of thinking, well, you need to get the ingredients. So, you know, if you sit down and write yourself a bit of a shopping list, particularly with COVID and the trouble of getting to the supermarket, hopefully it's a one-stop shop, or maybe you can buy it online. Having obviously some extra pantry stores, you know, that you can grab, some tinned fish, lentils, some of those convenience packets of rice are really great, to pasta sauces, yogurt, lots of things that you can easily, quickly make some quick, easy meals with is a real necessity to have on hand in stock. It's also, where you can, doing a bit of prep in advance. You know, it might be just chopping up when you're feeling a bit stronger and well on a Sunday afternoon, getting the family to sit around and chop a few, you know, containers of vegetables that you'll be able to throw into sort of, this is my bolognese mix, when you're whipping that up all across the week. It might be marinating some of your meats and things. So if you get a chance, just get that, what you're going to cook, and see if there's a few steps in there that you might be able to sort of get ready, bulk prep, because then, you know, it really does feel like magic when it comes to meal times if it's all ready, good to go. And then I guess to summarize, it's just balancing that plate and really distilling those kind of key recommendations. The Australian dietary guidelines overlap with the cancer preventative guidelines. It's about just filling up that plate with lots of colour, lots of green, lots of yellows, obviously reds, oranges. It's about a small portion of meat, or it could be using, as I said, you know, a plant-based alternative if that's what you enjoy or prefer. But that's kind of essentially, you know, how a plate, you want your plate to be really colourful and bright and interesting and have lots of textures and tastes and things to enjoy. Now I will make these available, but I'm just, because I know I'm short on time and I really just want to sort of throw as much as I can at you in a short period. I won't talk about the wonderful magical benefits of lots of fresh herbs and spices in food that can add lots of flavour, taste, but also those phytonutrient protective nutrients I mentioned at the outset. So I'm sharing with you a couple of my favourite spice blends and making up a couple of these and having them on hand and dishing them over you know, your grills or whatever you're cooking at home will really add a lot of great nutritional value as well as great taste. And I've just got a couple of my favourite other sort of recipes. This is good if the mouth is a bit sore or dry and you need something easy and soft to sort of enjoy. A lovely tomato salad, corn's sort of lovely salad with corn. You know, this is obviously a grill for a family. It's not a one-person serve. But again, whenever I'm having meat, I always surround it with lots of colour and freshness and herbs and vegetables. So it's sort of the good plant benefits alongside the protein, which is, as I said, important, particularly during the treatment phase. Another favourite, I know some people have often, you know, emotional eating or snacking can be a problem, and particularly for Victorians who are sort of a bit stuck at home, and so trying to choose a healthy, wholesome snack, and this is one with lovely herbs as a popcorn. So I guess in summary, I guess I'm just trying to share the guidelines, but at the same time really sort of inspire and encourage you to embrace good eating, enjoy it, be a little bit adventurous, try something new, something different. You're very welcome to go to my website, cannutrition.com.au, where, as I said, I'm developing the can cook recipes, and I'm building up a bank of special diet sort of recipes, not only for healthy eating, but to help, you know, with different side effects that can occur through the treatment. And also, I, you know, encourage you, if you are wanting to get a bit more detail personally about what your specific dietary needs could be, you know, look out for an accredited practicing dietitian, and to find out, you know, in your area where you could find one, or certainly in your treatment team, if there's one available, you can go to the Dietitians Association of Australia's website, and certainly there's a registry there. So I thank you, and I leave you with a lovely carrot cake, which is made with wholemeal flour and nuts and seeds in it, and a little bit of lovely cream cheese, low light cream cheese icing to enjoy for dessert. Thank you.
Jane, that was a lovely presentation. Unfortunately, it's made me quite hungry.
I know, I'm hungry as well, Alison. It's very past my dinner time.
However, we have had a lot of questions come in, so don't go away. But so if you would like to stop share screen, we'll go with our next speaker. Thank you very much. So our last but certainly not least speaker for the evening is Dr. Teresa Lee. She is a physiotherapist who specialises in lymphedema and musculoskeletal problems related to cancer care. She attained a PhD in physiotherapy in 2008. She has currently appointments at the Melanoma Institute Australia and the Royal North Shore Hospital, and is a research associate at the University of Sydney. Teresa was the New South Wales representative for the Australasian Lymphology Association 2012-2014, and was the Australian Physiotherapist Association New South Wales Chair of the Cancer Palliative Care and Lymphedema Special Interest Group for 2012 to 2019. Teresa was the convener of the 12th Australasian Lymphology Association Conference and won the 2017 Australian Physiotherapy Association New South Wales Branch Award for Outstanding Contribution to the Profession. Tonight, Teresa is going to discuss exercise and managing immuno and targeted therapy related fatigue. Welcome, Teresa. Thank you.
Thank you, Alison. I realise we are a bit short of time. I have actually pre-recorded my my presentation, so without much ado, I will get started on this. Alison, can you tell me if you can see my first slide?
Yes, I can.
Good.
Yes, you just have to hit play.
Okay, off we go.
Thank you.
Hello everyone, my name is Teresa Lee and I'm a physiotherapist at the Melanoma Institute of Australia. I'm here to present to you about exercise, fast facts for melanoma patients. So why do we want you to exercise? There is a multitude of benefits to you and your body. Firstly, exercise can help improve your physical function, including your flexibility. Exercise can make you stronger, it can improve your balance, and it can improve your bone health or bone density. Exercise helps to keep you within your healthy weight range for your height. Exercise can improve your mental well-being. It can help with your self-esteem, with your mood, and your quality of life as it goes through the ups and downs of melanoma treatment and melanoma management for the long term. Exercise can help improve your blood and your lymphatic circulation. Exercise can reduce treatment-related fatigue, particularly in those patients undergoing immunotherapy treatment. And I'll talk a little bit more about this later. It can improve your sleep quality. Exercise can improve your heart and your lung function. And it has been shown to reduce cancer reoccurrence rates, particularly for breast, prostate, and colorectal cancers, but there's no reason why this benefit cannot extend to melanoma patients. This is quite a common perception about exercise for our melanoma patients undergoing immunotherapy. I haven't pushed my body at all. I played high-intensity team sports prior to diagnosis and treatment, but I haven't started that again because I'm too scared of how it may affect my body, and I'm too fatigued to start the training. I'm sure that quote rings true for many of you out there today. A few years ago, MPA started a survey project specifically looking at the exercise behaviours of patients receiving immunotherapy for advanced melanoma. Of the 55 people that completed the survey, just over half described that they were exercising, and they included activities such as walking, swimming, weights, exercise classes, yoga, jogging, golf, gardening, Pilates, and group sports such as netball and football. The participants of the survey described a range of physical and emotional benefits, and the most predominant benefit was that of fatigue reduction during the course of immunotherapy. Interestingly, 64% of those patients that answered the survey also said immunotherapy side effects did affect their ability to exercise. Hence, fatigue itself was a barrier to exercise. However, many of their participants were able to modify exercise so that they could continue to do it during immunotherapy and thereafter, despite the fatigue experienced. So let's talk about exercise modification. So this is the statement of one of the participants in that survey I talked about. She said, "After my last treatment, I have had some flank pain and have been feeling lethargic and more tired. I've done less than I normally would. I've been doing gentle swimming rather than lapping." So she was able to modify her exercises with respect to the side effects that she was starting to get from her immunotherapy treatment. So in terms of our advice to you about exercise modification, yes, this may be required in order to make exercise work for you during immunotherapy and when you are countering the side effects of fatigue during and after immunotherapy. It is important to exercise safely without incurring an injury. And to do that, you need to be guided in exercising gradually and pacing your activity. A lot of this depends on your fitness level prior to your melanoma, your age, and other medical issues. It may also depend on your stage of treatment and your recovery. Given that we are talking in the context of melanoma, it is important you choose when to exercise and the type of exercise safely. So we would certainly recommend that you exercise when the UV index is low, below 5. And you can check this on the internet or on various apps that are available. We don't want you to be exercising in the middle of the day when the UV index is high. You may also want to take into account other treatment-related side effects. For example, for those of you on BRAF inhibitors, the photosensitivity and the likelihood of sunburn that can occur. Lymphedema is another issue for those who have had lymph node dissection. Sometimes with immunotherapy, there are issues to do with inflammation. Some patients may experience dizziness or poor balance and coordination. Hence, it may be safer to exercise in certain environments or with someone close by. The recommended target for patients is 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise, plus 2 to 3 sessions of resistance exercise per week. These are the guidelines outlined by the Clinical Oncological Society of Australia. Now, you may look at this and think, wow, there's no way I can complete this amount of exercise at the moment or the way that I'm feeling at the moment. And that's perfectly fine. That is the end goal. Okay, it doesn't necessarily mean you have to start off with 150 minutes of moderate intensity exercise per week straight away, particularly when you're in the midst of immunotherapy treatment or you're in the midst of experiencing the side effects related to immunotherapy. Work with your physiotherapist or your exercise physiologist to build up slowly and pace yourself until you are able to achieve that end goal. It could take months, it could take years. Don't be hard on yourself. It's important to modify the exercises so that you don't incur an injury and that you are able to finally achieve this recommended target for the long term. Just going back to what moderate intensity exercise means. It means you will have a faster than normal heart rate when you're exercising. You will breathe harder than normal, so an increased respiratory rate. You will sweat, so exercise to the level of when it gets you to sweat. So that includes brisk walking, dancing, cycling, swimming. So here are some tips for planning your exercise. You may want to exercise with a friend or a family member to stay motivated. Or you may want to do that because you have poor balance and you want to have someone close by. Some of you may want to keep track of your progress, and that is quite helpful as a motivating device. Apps, step counters, Fitbits that track how many steps or how many kilometers you do. They're very helpful. I personally like to mix it up a little bit. I like to do a little bit of cycling, a little bit of walking and jogging. I like to do a little bit of weights, some indoors, some outdoors, and participate in some group activities as well. So each to their own, but mixing it up is helpful, and I think it lowers the risk of injury. Obviously, have some options for bad weather. so indoor exercise. So for me, I've actually purchased some secondhand gym equipment during the COVID lockdown so I can exercise safely indoors. Finally, finding help. Look, everyone is different, and an exercise program is not a one-size-fits-all approach. You are not trying to beat the person next to you. Everybody has a different reaction to immunotherapy, to surgery, and you cannot pace yourself with the patient next to you in the waiting room. Compare you to you. Don't compare yourself to others. Physiotherapists and exercise physiologists are important to guide you through this process of tailoring your exercise. In particular, physios and exercise physiologists with an understanding of melanoma and cancer care can be very, very helpful because they understand the sort of treatments and side effects you go through. I would recommend that you ask your melanoma treatment centre for particular referrals to these physios and exercise physiologists. Thank you very much for having me.
Thanks, Teresa. That was terrific. So I guess we will have you and Jane come back on, and we have quite a few questions and that people have sent us actually as before the webinar and then during the webinar. And I'm not sure whether this one would be for Jane Freeman, sorry, two Janes here, or for Michael. But one question that comes up regularly and has come up this time is, do cancer cells thrive on sugar? Should I have a sugar-free diet?
I'm happy to take that one. Yeah. Yeah, so the answer is yes and no. It's a bit more complicated than that. Every cell in our body is energized or charged with glucose, which is the sort of the sugar that we have in our blood, and we need that in there. Otherwise, you know, we wouldn't function. But I guess the idea of totally cutting out sugar to starve our cancer cells is a little bit counterintuitive, because by doing that, and particularly if you're restricting your diet, you know, you're potentially starving your body of the fuel and the energy it needs to function and stay strong and to help, you know, fight and cope with the treatment. So what we suggest is small amounts, you know, in the context of the sort of healthy, predominantly plant-based diet that, you know, I discussed in my presentation as recommended. And of course, there's also the ketosis diets. And again, you know, as I tried to sort of emphasize, diet is not meant to be some sort of arcane magic that we can manipulate and alter to sort of cure or fight cancer. There are no diets per se that, you know, have any evidence of actually being able to fight or stop cancer growth per se. So I really steer people back to a good, healthy, protective, plant-based, wholesome diet. You saw my Wheat Bix slice. You saw if I'm making a pudding, sometimes I'll try and use better flour and I'll throw some fruit in. I'll always try and improve the nutrition benefit of the thing. The other thing we have to be just, of course, careful of is just trying to maintain a healthy weight. So obviously eating too many sugary drinks, very high sugar foods can contribute to weight gain. And that in itself can be a bigger risk, you know, for certain types of cancer. So really encourage people, the answer is no, but, you know, obviously not overdoing sugar, but enjoying small amounts as part of a healthy diet is what we'd recommend.
Great. The next question I have is that there's not a recommendation to use supplements, but what about vitamin C or vitamin D or omega oils, or so what about those? And someone has also asked, does zinc boost the immune system? So in short, what is the story on taking supplements?
Well, I guess, I mean, if it's in reference to sort of can it help your immune system, your immune system is a very big, complex organisation, and definitely it does better when, you know, it's well nourished, it's well fed, it's well supported with nutrition. In fact, our immune system uses about 1/3 of our total food energy intake, so it does utilise a lot of what we eat to function well. But it's a very multi-layered, complex system, and there's, yes, all of those key nutrients are important, but they will, you know, delivering them in your diet adds so much more and supports your immune system in such a better way than if you take these sort of one-off ad hoc mega doses of certain supplements. Body's very finely tunedly balanced, and nutrition works very finely with the amounts the body needs. It needs small amounts of these vitamins and minerals, but if we overdo it or mega dose, it can sometimes cause more harm than good. So I'd always really encourage people in the first instance to get their zinc from, you know, some good protein foods, to get their vitamin C by eating easily get their needs by eating a couple of pieces of fruit and up to 5 serves of vegetables in a day. Really start with meeting your basic food group requirements, because that will well and truly deliver, you know, the myriad of those food nutrients your immune system needs. If they're having eating difficulties or not managing to eat because of some of the side effects, well, then I'd really encourage you, as I said, to sort of talk specifically to your team so that we can look at, you know, what we could do. And then in some instances, yes, we might recommend some supplements, a multivitamin supplement to back you up if there's, you know, significant or real issues with you actually managing to get enough of these key nutrients in your diet. But certainly, look, I've had a patient once who came with 126 different bottles of supplements they'd been advised to take, and it's a heart-sink moment because you just know that, you know, spent a lot of money and obviously are trying to do something good, you know, in their diet. But I really wish they'd gone to, you know, the fruit and veggies section at the supermarket instead and splurged on lovely fresh fruit and real, you know, delicious vegetables, etc. Yeah.
So I just on the back of that, and I'm conscious because I do have one more question, and we do have to finish up. But so would it be better to go and see your GP or talk to your oncologist, certainly, and perhaps have a blood test to see if you are deficient in any minerals or vitamins before you would contemplate going on any supplements?
Yeah, absolutely. And certainly some key minerals. So, you know, looking at your iron is important. Certainly vitamin D, it's worth obviously looking at what your levels are in the first instance, because that'll also just help us decide what dose is maybe needed to help properly sort of address those potential issues. When it comes to vitamins, though, it's a bit of a tricky one. Vitamins, particularly the water-soluble ones, they break down very quickly. You know that, you know, you squeeze an orange and the vitamin C does oxidize quite quickly. And the same thing happens in our blood. So if you take some blood and then you send it off to the lab and measure your vitamin C, by the time it's got to the lab, you know, it'll give you a sort of a falsely low reading because it will oxidize in that treatment. So it's actually a little bit difficult to measure our absolute levels of some of those particular vitamins. But, you know, the better way is to just go back and look at the dietary guidelines and reference, are you having enough of serves of these key food groups? Because if you are, you know, unless there's a particular special need or issue, 99% of the cases you'll be meeting those key nutrient needs for, you know, optimized immune function through your treatment.
Great. And now the last question is about probiotics. We have heard from oncologists some time ago. I remember Professor Grant MacArthur from Peter Mac talking about that. It was that having a probiotic could affect, could lower the your response to immunotherapy. So in terms of, so that was his view. So in terms of, as a dietitian, what is your view?
Yeah, well, look, you know, probiotics were the big hope, you know, 5-10 years ago. Somehow we could sort of work out what the good bacteria were and load them into the gut, and, you know, sort of our gut health would be happy forever in. But of course, it's not as simple as that. And our guts are very complex. The immune system's very complex. And we have our own families of gut bacteria that are obviously working in our bodies and doing the jobs they're doing. So this idea you can add in different ones and displace what's there, in this case is actually shown to be, again, more harmful than good. And it's another good example, not just to grab that pill that makes that promise in the health food store or the chemist to take, you know, to help. You've got to sort of appreciate how complex our bodies are and how things work. So in the case of probiotics, actually what's more helpful is probably using more what we call prebiotics. So they are the cruciferous vegetables, the high fiber foods, and what they actually do is act like fertilizer and actually help feed our naturally inherently good bacteria that are in our gut, and building up our own populations of our good bacteria that are already in our body and working in our immune system sort of as needed is a better strategy than certainly trying to sort of supplement with the probiotics. The other thing with probiotics, that track down to the gut is very treacherous. So you'll see on these probiotics, there is billions and billions of these allegedly bacteria in these pills, but by the time they actually get through the acid in the stomach, the small intestines, get down to the large bowel, very little make it anyway. So they have a sort of fairly small effect in reality. So yeah, again, looking back to filling up on fiber, good vegetables and fruits will do a lot more for your healthy gut bacteria than sort of taking probiotics.
Okay, thank you very much, Jane. So we are coming to a close now, and I'd like to thank everyone for the great questions that they've sent us in before tonight's webinar and during. So on behalf of MPA and our guest speakers, Professors Jane Turner, Michael Jefford and Jane Freeman and Teresa Lee, I thank you for coming along tonight and taking time out of your family lives to come along. That's been fantastic. I very much hope everyone has enjoyed this webinar and found it informative. I would like to add, however, if any of the presentations tonight have triggered any thoughts or feelings you'd like further support with, please contact our national support line on 1300 884450 during business hours, or you can go to our closed support group for peer support, or if you need immediate support, you can call Lifeline on 131114. One more thing, I'd like to remind you all that this is a 4-part series symposium, and our part 3, our number 3 webinar will be at the end of October, and we will be having our speakers talk about immunotherapy, the latest updates, neoadjuvant therapy, clinical trials, and importantly, we'll have a patient speaker talk about their experience of being on a clinical trial and how positive it was for them. We will automatically send out the link for you to register, and I'm sure you all will. All right, many thanks everyone for coming along tonight. Good night.